Welcome, everybody, to Wonderful Wednesday. And today we're going to talk about some of the cues and clues in the top 5 cues and clues, actually, in cardiogenic shock and cardiac shock. And so this is really a clinical talk, talking about what we see at our patient's bedside and the kinds of things that tell us we have patients at risk. So just really important in terms of how we're looking at our patients. So this is a 36-year-old patient with no history of heart disease or heart failure who presents with acute chest discomfort. And here's the EKG from the admission desk or the triage desk in the emergency department. So taking a quick look at that EKG, I think everybody would agree that this EKG does not look normal. Yes, everyone is going to agree that. So the first thing that we always want to do is we just want to quickly look at the axis. We remember that for normal axis, you have to be upright. The R wave must be upright in lead 1, and it must be upright in AVF. Well, here it's upright in lead 1, downward in AVF. Remember, this is not an EKG class. That's something you have to attend separately. But what we already know is the patient has a left axis deviation. Upright in 1, downward in F. Patient has the left axis deviation. So that's the first thing we're going to do. The second thing we're going to do is we're going to look for what's known as R wave progression, meaning I expect a small R wave or no R wave in V1 and then bigger, bigger, bigger as it goes across the chest. But what I see here is a big R wave in V1. That is abnormal. The next thing I'm going to do is look at the width of the QRS, which is about 0.12 to 0.14. That's also abnormal. Direction to the right. Abnormal width, this patient has a right bundle branch block. Now, right away, that tells you something is wrong. You have a right bundle branch block with a left axis deviation. That typically is occurring because your patient has had a myocardial infarction or because part of their left bundle is dysfunctional. Both things beyond what we have to discuss here. The next thing we're going to do is we're going to separate our leads into lead groups. So remember, that's going to be 1, AVL, V5, and V6 for lateral. 2, 3, and AVF for inferior, V1 and V2 for anteroseptal, V3 and 4 for anterior, remembering 5 and 6 are anterolateral. And what I'm looking for is ST segment elevation. So I look at lead 1 and AVL. I have very discrete ST segment elevation in lead 1, not in AVL, but in V5 and in V5 and in V6, I have ST segment elevation. Okay, so I already believe the patient is having a lateral STEMI. Then I look at 2, 3, and AVF, ST segment elevation 2, 3, and AVF, inferior STEMI. Okay, so looks like an infralateral STEMI, and it looks like I may have some anterior changes as well when I'm looking at V3 and V4. In other words, this is a very abnormal EKG. This is a young patient who does not have known heart disease. And one of the first things that I'm going to consider is a significant portion of my patient's wall is infarcting, which means that it automatically is putting them at risk for cardiac shock. So whenever you have a large anterior or a large infralateral or infraposterior MI, you should be prepared for the evolution into cardiac shock. This is your patient's chest X-ray. Okay, well, this is a very wet-looking chest X-ray. It's a little bit low penetration, but it doesn't matter. We don't really see much air. We've got a lot of infiltrates bilaterally. Not the best chest X-ray that was ever shot, but we can clearly say that the lungs are wet. Now, we may not know why, except we marry the wet lungs to the EKG changes, and we say, we think this patient is in cardiac shock. And sorry, I thought I had an echocardiogram here, but I guess I don't. So our patient presentation is they have severe and abnormal difficulty in breathing. The heart rate is up 120. Patient's weight is up 6 kilograms since the day before yesterday. And in presentation, they have said, I can't really walk any distance. I can't even walk to my mailbox. I can't walk from one room to the other to the bathroom without being short of breath and really completely fatigued. And they can't fit their shoes on. Okay, well, so I've given you some intensive signs, the EKG and the chest X-ray, and I'm so sorry because I also had the echocardiogram. I don't know what happened. But I'm also giving you some basic clinical signs. Patient's weight is up. They're having trouble breathing. The lungs are wet. You know that from the chest x-ray and from the difficulty in breathing. They've gained weight. Where is that weight? They're not eating Ben and Jerry's ice cream. They can't walk. They can't fit into their shoes. I'm going to add to that some of their basic lab values. Patient's BUN is 30 and the creatinine is 3.1. 4 months ago, the patient's creatinine was 1.2. So you've had a significant increase in creatinine, which typically indicates that you have a significant decrease in renal blood flow and creatinine clearance. We already know from the chest x-ray, the patient has bilateral pulmonary edema. The troponin is quite elevated, it's 34,000. Now, lots of times with chronic conditions, you can have a high elevation in your troponin. That's why if you are concerned, your patient is infarcting at the same time. So that communicates with troponin, but your patient also has a chronic disease, or at least the beginning of a chronic disease, and that is heart failure. The patient's got heart failure because the BNP is 800. Remember, normal BNP is less than 100. Anything greater than 200 is going to give you cause for concern. Patient's lactate level is elevated. That is not an indicator for sepsis. Remember, lactic acid goes up in hypoperfusion states. So you always look at lactate, and then you combine that with the patient's space deficit. We look at the ABG, the pH is 7.34, just mildly on the acidotic side. PO2 is 75, quite hypoxic. Patient's on 5 liters nasal cannula. PCO2 is 35, so you're not having a problem with ventilation, you're just having a problem with oxygenation, which is very common in pulmonary edema. And the bicarb is 17, normal bicarb 22 to 24. 26 and the perfect bicarb 24, your bicarb is down. And remember, when bicarb is down and base is down, that always means metabolic acid is up. So your patient's in metabolic acidosis. It's pretty mild. It's probably going to get much worse if you don't do anything about it right now. So I'm bringing all of this information, like my doctor is looking at the chest x-ray, I hope. I did the EKG. I'm the first one to see the EKG. I'm letting them know the EKG has been done, that I'm concerned about it. I'm looking at the chest x-ray. I'm letting them know that the chest x-ray is done and I'm concerned about it. But I have to be really clear when I'm communicating. The chest x-ray looks like you have pulmonary edema. The EKG looks like our patient is having a STEMI. The troponin is elevated. The BNP is elevated. The patient has lactic acidosis. The bicarb's down. The base is in deficit. The lactate is up. This patient's really sick. And this patient, regardless really of what their blood pressure is, although evidence says systolic pressure less than 90 and non-responsive is an indication of cardiac shock, if you have evidence of volume. Okay, do you have evidence of volume? Okay, let's go back. Patient gained weight, can't walk, can't fit in their shoes. Do you have evidence of volume? Yes. Chest x-ray, bilateral pulmonary edema. Do you have evidence of volume? Yes. If the patient is hypotensive and acidotic, the volume you've got is in the wrong space. So the patient's got volume, but it's in the venous compartment. Pulmonary vein, systemic vein, indicating to you that you're gaining weight, that you can't get in your shoes, that your lungs look wet. Very simple strategy. Do you have volume? Yes or no? And where is it?
Yes.
My patient's got
wrong things.
Yeah, there is something wrong with them. My patient's got volume and it's in the wrong space. Now, can everybody agree that the patient has got volume? So yes or no?
Yes.
Everybody
Yes, the patient got volume. It's just in third spacing.
No, it's in the wrong space. We're not going to diagnose it. We're just going to say it's in the wrong space. I mean, third spacing is okay, but you have third spacing for other reasons, right? So here we're saying you have poor forward flow and high residual volumes in your vein. And that's why it's leaking into the interstitium. You can call it third spacing, but third spacing your volume without the indications of cardiac dysfunction can occur because your oncotic pressure is low or you've lost endothelial integrity, lots of reasons. So I want to really point this towards that I have cardiac dysfunction. And that's what I want to help my physician understand when I'm communicating with them by showing them that I've looked at everything that is really, really important when I'm evaluating the patient. Okay, now we're going to take a look at this patient. Okay, so this is your patient up here and also down here. These are two different times that the EKG is being done. But what you can see here is that you have an upright and a downward. You're not really sure what's what from lead one because lead one's waveforms merge with lead two. You see that you're upright in AVF. So what we're going to say right now is we think the patient has a normal axis. We go over here and we look at a small R wave in V1. It gets bigger in V2, should get bigger in V3, bigger in V4, 5, and 6. But something that's really important about this EKG, I think most important is what I'm going to call the Dr. Dollar criteria for evaluation of ventricular hypertrophy. If you can't differentiate where your waveform begins and ends, you have a ventricular hypertrophy. So this patient has both right ventricular hypertrophy and left ventricular hypertrophy, although I think in this case, we're going to be more concerned about left ventricular hypertrophy. So again, my purpose is not to get you to read an EKG. Have you got some other kinds of changes that might be concerning? Probably, but until I actually have someone else take a look at the EKG, I'm not going to say anything because I know that ST segment elevation can occur in V1, 2, and 3 when I have left ventricular hypertrophy. So that's kind of what my concern is. I'm going to have T-wave abnormalities when I have ventricular hypertrophy. So this EKG, although very concerning, I would never diagnose this myself, and I'm pretty good with EKGs. I would not say that this was a STEMI. I would say this is uncertain. And I want a cardiologist to take a look at it, not a first-year resident or a second-year hospitalist resident. They don't have the bandwidth to look at a complex EKG. That's okay. They study a lot of things, but EKGs are not their mainstay of study. I need a cardiologist to look at the EKG. Then I look at the chest X-ray, and on my chest X-ray, I can see that the heart is very, very large. Now, traditionally, you're going to say, oh, that looks like a really large heart that doesn't empty very well, and you'd be right to say that. I have a really large heart that's not emptying very well. That's why the heart gets bigger, because it's got a lot of volume in it, and we're going to call that cardiomyopathy. But what's really important is you can see these straight up and down vascular lines. And this is one of the best EKGs I've ever seen that indicates these lines. This is vascular engorgement that occurs, excuse me, when I have heart failure. And that's called curly B lines. Now, I'm not trying to make anybody be a radiology expert. That is not my point. My point is to look at this and say where it should be completely clear, there's a lot of white, and that white occurs either because you have tissue or because of vascular absorption. I'm sorry, I'll have to excuse myself for 1 second. This is a really overwhelming secondary benefit from having COVID for sure. So I can see those vascular lines, and those are called curly B lines. Now, I'm not trying to make anybody be an echocardiographic expert. I am not an echo expert. When I look at this echocardiogram, what I want you to see over here, this is your right ventricle. So on your left side is the patient's right ventricle, and on your right side is the patient's left ventricle. Sorry. The right ventricle should be very large, and the left ventricle should be much smaller with a good ventricular wall. What you're seeing here is exactly what you saw here, and that is that you've got a lot of volume in the ventricle, and the ventricle isn't emptying, which indicates to us what we would call reduced ejection fraction cardiac failure. Now, you don't have to know that. I'm so sorry, everybody. Oh, my goodness. I'm going to stop recording because nobody wants to hear this. Not you, not me either.